All right, so for my evidence-based project, I did how do you effectively assess and treat visual and visual spatial neglect in stroke patients. My objectives are what is it and what are the causes of visual and visual spatial neglect? How do you assess visual and visual spatial neglect deficits and how to treat those deficits? So for my first objective, it is what are the causes of neglect and what is it exactly? So visual spatial neglect is a cognitive deficit characterized by a reduction or loss of spatial awareness of the contralateral side. And visual neglect is a disorder of attention in which a patient exhibits a lack of response to stimuli in one half of their visual field. Visual patients, visual spatial neglect is a common result of a stroke or a TBI. 82% of patients get this type of neglect with right hemisphere stroke, and 65% get it with a left hemisphere stroke. So it can be as simple as sensing simple environment stimulus to as complex as whole body organizational problems during navigation of any kind. The extent of the pathology varies on the location of the lesion and the rate of spontaneous recovery, most commonly associated with a lesion in the right hemisphere that causes impaired detection of the contralateral side of the body. Areas of neglect can be from damage to the posterior parietal areas, frontal lobe, basal ganglia, putamen, caudate, and or thalamus, and the damage to the right parietal attentional shifting mechanisms causes inability to disengage attentional resources from stimuli on the right side, which can cause difficulty engage left-sided stimuli. So initiating motor movements on the neglected side of the body during a rehabilitation can activate intact cortical circuits, and this can possibly be the cause for compensation from damaged areas causing neglect symptoms. So there are definitely complications with this type of neglect. Those with this type of neglect commonly are unable to understand or perceive their own illness, and this causes a failure to recognize the importance of participating in rehab. This can often place a burden on the family, caregivers, or medical personnel working with the patients, and it is important to find a technique such as a game to help the patients raise awareness of the importance of recovery. For example, you could have like something that a patient likes spread out in front of them on the left, right, and center sides so they can see, and you're going to have them pick up all the items that they can see, such as money, snacks, or toys. And all the items that they pick up, they get to keep. And of course, they won't be able to see any of the items on their affected side because they will forget to look. And you're not supposed to cue them until after they thought they had picked up all the items that they see. And by showing them that they missed items on the neglected side, this will help them have like a visual to their deficit, and it will help with their motivation to comply in therapy. Although this technique only works once, it has been shown to be useful to showing the importance of rehab and to increase motivation. Other complications include hemiplegia, apraxia, hemianopia, amnesia, spasticity, DVT, seizures, hearing impairments, tremors, headaches, cardiovascular complications, etc. For my second objective, it is how to assess visual and visual spatial neglect deficits. So when it comes to recovery, our main goal is decreasing the damage of the injury. So you can do this through spontaneous, assisted, or no recovery at all. And the way to recover is to take intact neural circuits on the functions of the damaged areas, cerebral recognition through exercise, and the replacement of neurons. So this is also called neurogenesis. So when it comes to assessing this type of neglect, the occupational therapy role identifies the visual deficits that affect the ADLs of the patient and assesses their visual field through testing vision and controlling of the eyes. And for physical therapy, our role is to assess the patient's balance, posture, gait, and coordination. Neurological testing can be used to address body function and structure, and really assessing all aspects of neglect from form discrimination, like judgment, subjective visual axis. We can use the ICF model, which has body structure and function, activity, participation, and environmental factors. And there's a couple of functional outcome measures you can use. So you have the Visual Recovery Index, which assesses reading, picture scanning, phone dialing, addressing and sentence copying, telling and setting time, coin and card sorting, and map navigation. And then you also have the assessment of motor and processing skills, which identifies problems with different ADLs. So for my third objective, you have the treatment of visual and visual spatial neglect. So when it comes to rehab, occupational therapy really focuses on scanning and locating objects in their blind visual field, negotiating traffic, and completing ADLs. So for visual scanning activities, you can do light board, hallway scanning, orienting to neglected side. You can do movement and perception of stimuli on the neglected half, like drawing a line, object, letter cancellation, drawing, reading, mental imagery, body attention. You can also do reading, picture scanning, phone dialing, addressing and sentence copying, telling and setting time, coding, card sorting, and map navigation. And there's also a form of eyeglasses that you can use that track eye movement, and they beep when you're not observing the neglected side as a cue to look at that side. You can also do active and passive manipulation of the neglected limbs. And then you have electrical stimulation for muscle motor recruitment. And then you have ADL training, such as making coffee, preparing dinner, setting the table, etc. Just daily things that you need to do and you don't really think about unless you have an injury or an illness. For physical therapy, you can complete balance activities, posture control, body mechanics, coordination training, and gait training. Most of those activities can be dual task training, which is really good. So you have static and dynamic balance training in sitting on multiple surfaces. So for example, you could do various sitting surfaces with modifications of difficulty, balloon tapping, tapping a therapist's hand, picking up cones, and moving and stacking cones. It's all done in sitting. And then you can also do the same thing for standing. So standing on various surfaces with modifications of difficulty, balloon tapping, standing marches, leg kicks, standing on colored objects, and or standing with colored objects in a circle around your patient, and your patient has to touch the given color with their foot while remaining upright. And then you can also do moving and stacking cones. You also have hand and eye coordination training. You can do this in sitting and standing. So for example, you could do ball toss, beanbag toss, playing the Wii, bouncing the ball on the trampoline, stabbing objects, and balloon bouncing or tossing. You can also do gait training with and without an assistive device. You can walk in the hallways, outside, through cones, and through an obstacle course. It is also important for strengthening the core, the upper extremity, and the lower extremity to help with balance and posture. So a couple tips for rehabilitation is you want to have the patient focus on only using the neglected side and try not to use their unaffected side for tasks and activities, because you really want them to focus on using that affected side. So if you're allowing them to use the unaffected side, you're kind of teaching them that it's okay to compensate. And you also want to complete activities that work on actively involving the affected side. So if the patient cannot actively move that affected side, it's important to passively move the affected side to help train the patient. And you really want to spend time on functional activities such as combing hair, applying makeup, placing items in a basket, etc. This allows the patient to feel like they're gaining their independence, which also helps them motivate themselves and want to continue with their care and rehab. And then scanning and cueing strategies have proven to be the most successful rehab help when it comes to patients with visual and visual spatial neglect. So you really want to emphasize on doing that during therapy. And so lastly, for my teaching and learning, I kind of stuck a couple different types of neglect here because I felt like that's not very touched that often, and a lot of the therapists in my clinic agreed. So for the unilateral neglect, they're really unaware of their own body that belongs to them, and it's caused by a lesion or injury to the premotor cortex and is responsible for body part ownership. So the stroke is typically in the middle cerebral artery, and the patient ends up with postural deformities and not using that side. They want to stand on the affected side, so the patient is encouraged to scan to the neglected visual field. It is important to do activities that involve that affected extremity. For sensory neglect, you want to be, they are unaware of sensory stimulation on the opposite side. So that is visual, auditory, and tactile. For auditory, you have the inability to listen on the affected side. So for example, their left side is the affected side. They typically would shift towards the unaffected side when locating sounds. So you can do this through testing their hearing. So you have two different stimulus that are present through earphones that go off at the same time, and ask them which one that they hear. And it is typically associated with right hemisphere lesions, which means you most likely will have effects on the left side. And then you have tactile, which is the inattention to tactile stimuli on the affected side of the body, and is commonly inaccurately diagnosed with the inability to feel sensations. So with tactile, it spares the primary somatosensory cortex, unlike hemianesthesia. And you can do this through neuropsychological based procedures that are incorporated with the standard neurological examination. And you want the patient to focus more on spatial and less on sensory. You also have motor neglect, which is the failure to generate movements in response to a stimulus, even though they are aware of that movement. So the patients have poor use of their limbs and the inability to complete bilateral tasks, and they also lack gestures on that affected side. And the deficits of strength, reflexes, and sensibility do remain intact. They just can't complete that movement. For representational neglect, the patient ignores the contralateral half of the internally generated image. So with mental representations or visualizations of the task, action, or environment, they can only draw half of the image they think of. And you can do this through testing and having the patient draw a clock or another image, which I do have a picture on the bottom of my presentation. And then you also have personal neglect. That's the lack of exploration and awareness of the contralateral side of where the stroke is occurred, and they may only comb one side of their hair. And then you have spatial neglect, where it's a failure to acknowledge stimuli on the contralateral side of the stroke, and you may only eat half their plate. So I'm sorry I talked really fast. YouTube only lets me have a 15-minute video, and this is a very hefty presentation. So if you have any questions, just let me know, and I can definitely answer those for you.